In this video, we will discuss hypercalcemia, which refers to high levels of calcium in the blood. We will explore its causes, how to diagnose it, and its management. Let's begin by looking at primary hyperparathyroidism, a common cause of hypercalcemia. Hyperparathyroidism is the main cause of high levels of calcium in the blood. It is usually caused by a non-cancerous tumor called a parathyroid adenoma. Diagnosis involves a medical history, exam, and lab tests. Surgery to remove the adenoma is the main treatment. Malignant hypercalcemia is a complication of advanced cancers, causing high levels of calcium in the blood. Symptoms include fatigue, anorexia, nausea, constipation, and mental changes. Treatment involves addressing the cancer and using medications to lower calcium levels and relieve symptoms. Vitamin D plays a crucial role in calcium metabolism, but excessive consumption or abnormal metabolism can result in vitamin D-mediated hypercalcemia. This condition can arise from excessive supplementation, increased sun exposure, or underlying diseases such as granulomatous disorders or sarcoidosis. The pathophysiology involves increased intestinal absorption of calcium, enhanced bone resorption, and enhanced renal reabsorption of calcium. Symptoms may include fatigue, weakness, nausea, and constipation. Treatment typically involves discontinuation of vitamin D supplementation and the identification and management of any underlying causes. Certain medications can cause hypercalcemia through various mechanisms. For instance, thiazide diuretics can increase calcium reabsorption in the kidneys, resulting in elevated serum calcium levels. Lithium, commonly used to treat bipolar disorder, can impair the function of the parathyroid glands, leading to the release of excess PTH and subsequent hypercalcemia. Furthermore, certain medications can interact with calcium-regulating hormones, such as PTH, vitamin D, or calcitonin, thereby affecting calcium homeostasis. Recognition and management of medication-induced hypercalcemia involve medication adjustments or discontinuation under the guidance of a healthcare professional. In rare cases, hypercalcemia can reach severe levels and lead to a hypercalcemic crisis, which is a medical emergency. This condition can result in life-threatening complications, including cardiac arrhythmias, renal failure, and altered mental status. Immediate measures in managing a hypercalcemic crisis include aggressive intravenous fluid administration, preferably with normal saline, to increase urinary calcium excretion. Bisphosphonates, such as pamidronate or zoledronic acid, can be used to inhibit bone resorption and decrease calcium levels rapidly. Calcitonin, corticosteroids, and dialysis may also be employed in severe cases. Familial hypocalciuric hypercalcemia, FHH, is a rare genetic disorder characterized by impaired renal calcium excretion, resulting in mild and often asymptomatic high calcium levels. It is caused by mutations in the calcium-sensing receptor, CASR, gene. FHH is usually detected through routine blood tests and may present with mild fatigue or muscle weakness. Distinguishing FHH from primary hyperparathyroidism is important for proper management, which involves genetic testing and evaluation of calcium and parathyroid hormone, PTH, levels. In hypercalcemia, imaging techniques such as plain radiography, DEXA scans, CT scans, and MRI scans are crucial for evaluating underlying causes and potential complications. Radiographs can identify hyperparathyroidism or bone lesions. DEXA scans assess bone density and detect osteoporosis. CT and MRI scans provide detailed images that aid in identifying tumors or other pathologies. Accurate interpretation of these imaging studies is essential for diagnosis and management planning. Renal tubular acidosis, RTA, is a kidney disorder that affects acid-base balance. It can cause high levels of calcium in the blood, hypercalcemia. In type 1 RTA, impaired acid excretion leads to high urine calcium and kidney stone formation. Treatment involves correcting acid imbalance. In type 2 RTA, impaired bicarbonate absorption results in alkaline urine and reduced calcium solubility. Treatment involves correcting bicarbonate imbalance and addressing calcium abnormalities. Hypercalcemia of immobilization occurs when individuals are bedridden or immobile for extended periods, such as in patients with severe illnesses, long-term hospitalization, or immobilizing injuries. The pathophysiology involves increased bone resorption, reduced renal calcium excretion, and decreased activity levels. Prevention strategies include early mobilization, physical therapy, and optimizing calcium and vitamin D status. In severe cases, bisphosphonates or calcitonin may be considered. Understanding the mechanisms and implementing preventive measures can significantly reduce the risk of hypercalcemia in immobilized patients. Hyperthyroidism, characterized by excess thyroid hormone production, can lead to various metabolic disturbances, including hypercalcemia. The mechanisms underlying hypercalcemia and hyperthyroidism are multifactorial. Increased intestinal calcium absorption, enhanced bone resorption, and altered renal calcium handling all contribute to calcium imbalance. A comprehensive management approach involves correcting the underlying hyperthyroidism through antithyroid medications, radioiodine therapy, or surgical intervention. Concurrent management of hypercalcemia may include addressing secondary causes and providing appropriate symptomatic treatment. Granulomatous diseases like sarcoidosis and tuberculosis can cause hypercalcemia by activating vitamin D, increasing calcium absorption. Diagnosis challenges arise due to systemic involvement and multiple organ impact. Accurate diagnosis requires detailed evaluation of clinical history, radiological findings, and laboratory investigations for appropriate management. In some cases, hypercalcemia may recur despite initial successful management. Recurrent hypercalcemia necessitates further investigation to identify the underlying causes and guide long-term treatment strategies. Treatment options may include surgical resection of recurrent parathyroid adenoma, considering alternative medications that do not cause hypercalcemia, or treating any underlying conditions contributing to hypercalcemia. Long-term monitoring is crucial to prevent complications and maintain optimal calcium levels. Regular monitoring of serum calcium, PTH, and kidney function ensures early identification of any changes, allowing prompt intervention when required. To summarize, hypercalcemia is a complex condition. Identifying underlying causes and tailoring treatment strategies are essential. This video offers detailed insights to aid medical professionals in managing hypercalcemia effectively.